Welcome to Mega King, home of the Bun Burger. Let's grab a booth and settle into the super important and delicious issue of acute kidney injury. In this sketch, we'll cover each of the three categories of AKI individually. But first, let's get some definitions out of the way. Acute kidney injury is a decrease in kidney function that occurs, get this, acutely. The acute in acute kidney injury means that the decline in renal function occurs over hours to days. This decline in function can lead to retention of urea and other nitrogenous waste products, as well as dysregulation of extracellular volume and electrolytes. Since the early definitions of AKI were numerous and non-standardized, the Kidney Disease Improving Global Outcomes, or KDIGO, came up with an official definition. Well, three actually, of which you only have to meet one to officially have AKI. The first two criteria are based on creatinine, which isn't surprising since this filtered metabolite is reflective of GFR, and therefore we use it to monitor most things kidney. For this, we brought in our recurring sketchy symbol for creatinine, the creatinine credit card. Cha-ching! And above the screen, you'll find the criteria written on the wall. The first definition of AKI is an increase in serum creatinine of 0.3 milligrams per deciliter or more within 48 hours or less. AKI can also be defined as a rise in serum creatinine to 1.5 times the baseline creatinine within 7 days or less. You might sometimes see this written as a 50% increase, but if you're any good at math, you can see that it's actually the same thing. This definition is helpful for patients who already have an abnormally high creatinine at baseline, like patients with some degree of chronic kidney disease already, or an abnormally low creatinine at baseline, as with small elderly patients or cirrhotics with muscle wasting. The third criteria for diagnosing AKI is a urine output of less than 0.5 milliliters per kilogram per hour for at least 6 hours, illustrated by this tiny trickle of lemonade from the drink dispenser. This means you can diagnose AKI by either laboratory findings or clinical observation. Moral of the story, a rising creatinine can define acute kidney injury by both an absolute value or a proportional increase. Furthermore, you can bypass the lab findings and diagnose AKI by observing the urine output. Keep all that in mind, it'll come back soon. AKI comes in three types, and it's based on where the insult is occurring: prerenal, intrinsic, and postrenal, which we'll illustrate in the left, middle, and right areas of the sketch, respectively. Each type has a characteristic pattern of findings that will help you narrow down the diagnosis and stop the injury. First up, on the left side of the sketch, prerenal AKI, which means the problem isn't in the kidney, but before it. Prerenal AKI is caused by decreased renal perfusion. To help you remember decreased flow in prerenal AKI, think of this tiny trickle going into the right kidney-shaped cup. That's just not going to cut it. Decreased renal blood flow can result from absolute volume depletion, as with severe dehydration or hemorrhage, hypotension, as in shock, or decreased effective arterial blood volume, as in edematous states like cirrhosis and heart failure. Anything that causes low renal blood flow can cause prerenal AKI, so it's not surprising that prerenal AKI is the most common type of acute kidney injury that's seen. Over in the middle of the room, we're featuring intrinsic AKI. While prerenal AKI was caused by a problem upstream from the kidney, intrinsic AKI involves injury to the components of the renal parenchyma itself. Intrinsic AKI can be broken down again based on which structures within the kidney are affected most. For example, large vessels with renal artery thromboemboli, small vessels, and the glomerulus with cholesterol emboli or glomerulonephritis, the tubule cells in acute tubular necrosis, ATN, or the tubular lumen and collecting system with crystal nephropathy from acyclovir or methotrexate. Don't worry if that seems like a lot, we'll break those down later. For now, just remember that intrinsic AKI means actual injury to the kidney tissue. And last, on the right side of the room, postrenal AKI, which, as you might guess, occurs after the kidney. More specifically, the collecting system, ureters, or lower urinary tract are obstructed, causing back pressure on the collecting system and glomeruli. This in turn leads to decreased renal function acutely. A great example of postrenal AKI is urinary obstruction due to compression of the urethra by BPH. This fortunately is very easy to fix in most cases, but unfortunately the least common cause of AKI. Okay, so we'll use the three types of AKI, pre, intrinsic, and postrenal, to compartmentalize all the pathologies associated with AKI. And hold on to your pee, friends, because we're going to go through the workup of each of the three AKI categories individually. But first, let's go over an example of what you might see in a SOAP note for general AKI. Notice how the definition of AKI is largely dependent on very specific lab findings and careful urine measurement. It's no surprise then that the diagnosis of AKI is largely based on labs and eyes and O's and whatnot, with not much in the way of actual symptoms or physical exam findings. Since AKI is oftentimes completely asymptomatic, you'll notice the big smiling face on that Mega King sign. No symptoms there. So eat up, kids. All right, an acute decline in renal function oftentimes leads to decreased urine output, aka oliguria or anuria, represented here by this man's empty kidney cup. That being said, some patients experience no decrease or even an increase in urine output. Keep the more common finding of decreased urine output in mind because patients may complain of decreased urine output themselves, or in patients who are already hospitalized, a decreased urine output can be caught by reviewing their eyes and nose. When the kidneys are no longer able to excrete fluid, volume backs up, so assess for symptoms of volume overload in your patient. These include things like peripheral edema, especially in dependent areas like the lower extremities, shortness of breath from pulmonary edema, or if it gets severe enough, even anosarca, which is generalized edema everywhere. Acutely reduced GFR leads to the buildup of nitrogenous waste products in the serum, also known as azotemia. When azotemia is severe enough to start causing symptoms, then you've crossed into the threshold of uremia. But wait, you might ask, isn't uremia just urea in the bloodstream? Well, technically yes, but in practice, many physicians use uremia as the synonym for renal dysfunction, significant enough to cause clinically relevant metabolic problems. While uremia typically occurs in chronic kidney disease, it can also be seen in AKI. Just think back to the familiar symbols from the Jurassic Museum. A few of the first symptoms to develop are nausea, vomiting, and really intense pruritus. Patients with uremia may also have a multitude of neurologic symptoms. These include alterations in mental status that range from confusion all the way to acute encephalopathy, seizure, or even coma. In addition to mental status changes, other neurologic symptoms include tremor and asterixis. Finally, uremia can cause pericarditis. If present, patients most commonly complain of this sharp substernal chest pain that improves when they sit up and when they lean forward. All right, let's move on to objective findings associated with all forms of AKI, starting with the vitals and the physical exam. So, patients with AKI can present with hypertension even if they have no history of that disease. The cause is multifactorial. Mostly it's due to hypervolemia, along with increased renin-angiotensin-aldosterone activity in the setting of acutely decreased renal perfusion. And that nearly empty kidney cup, just a reminder that while not universally present, decreased urine output or oliguria and even anuria can occur with AKI. So always keep an eye on those eyes and O's. Technically, oliguria is a urine output of less than 500 mils per day or a sustained urine output of less than 0.5 mils per kilo per hour, while anuria refers to urine output of less than 50 mils per day, which is basically no urine output at all. Not surprisingly, morbidity and mortality for oliguric and anuric AKI are much higher than for non-oliguric AKI. On physical exam, check for those signs of hypervolemia, including peripheral edema of the pitting variety, and crackles or cardiac wheezing on pulmonary exam, which are signs of pulmonary edema. Uremia, if it's present, can lead to several physical exam findings. A friction rub is a sign of uremic pericarditis. The neuroexam might reveal weakness, unsteadiness, and tremor, myoclonus, and asterixis, signs of uremic encephalopathy. AKI is often a lab-driven diagnosis, so let's get to those labs, know what I mean? Starting with a basic metabolic panel. AKI, for the most part, revolves around azotemia, which is an elevation in creatinine and blood urea nitrogen, or BUN. Acute kidney injury can be defined by elevations in creatinine in one of two ways. an increase in creatinine of at least zero point 0.3 milligrams per deciliter within 48 hours, or 50% increase in the creatinine within 7 days. Don't just stop with the BUN and creatinine though. Look for hyperkalemia, which can cause potentially lethal arrhythmias and is an indication for emergent dialysis if it's refractory to medical therapy. Hyperphosphatemia and hypermagnesemia are also common in AKI. Conversely, the serum calcium is often low, primarily because of serum binding by phosphate. Decreased vitamin D production by the kidney can also contribute to this. And finally, acidic lemonade represents metabolic acidosis. It can be of either the anion gap or non-anion gap variety. The anion gap component occurs due to accumulation of sulfate, phosphate, and other metabolic anions, while the non-anion gap component can come from impaired hydrogen excretion in the dysfunctioning tubules. The take-home point, be on the lookout for metabolic acidosis. Renal biopsy tends to be reserved for patients with unexplained acute renal failure where the diagnosis is still uncertain. All right, with these basic subjective and objective findings in mind, let's take a look at the features that characterize pre-renal, intrinsic, and post-renal AKI, filling out a SOAP note for each category. We'll start with pre-renal over on the left. Remember that pre-renal AKI occurs due to decreased renal blood flow, which results in decreased GFR because, well, there's just less blood delivered to the filter. So, what are some findings that should point you in the pre-renal direction? First of all, look for things that could lead to hypovolemia. Look for GI losses such as vomiting, diarrhea, bleeding, or a high output fistula. Assess renal losses from diuretic use or skin losses from profuse sweating or burns. Pretty much any condition in which fluid is lost but not replaced, as illustrated by this hypo cup spilling out its contents. No refills at Mega King. So we'll start with third space sequestration of interstitial and intravascular fluid, which can also lead to hypovolemia and prerenal AKI. It's represented here by the hypo cup dumping some of its contents internally into the soda fountain drain. Some examples of third spacing include internal bleeding from things like trauma or ruptured aneurysm, for example. Remember, even with a hip fracture, the patient can lose over a liter of blood. Other things include small bowel obstruction, acute pancreatitis, peritonitis, and other severe inflammatory states. Severe hypotension can also decrease renal perfusion, causing prerenal AKI. Think of shock states such as hypovolemic, myocardial, or septic shock. In the setting of hypovolemia or hypotension, there's less blood reaching the kidneys, and on top of that, systemic vasoconstriction to preserve arterial pressure and blood flow to the brain means that even less blood gets to the kidneys. Stupid brain. Edematous states like heart failure or cirrhosis can also cause decreased renal perfusion and prerenal AKI. Yep, even in the state of hypervolemia. In the setting of decompensated cirrhosis, systemic vasodilation and splanchnic venous pooling results in decreased effective arterial volume. So keep an eye out for signs and symptoms of decompensated cirrhosis, things like ascites, peripheral edema, caput medusae, and jaundice. Okay, what about heart failure? In the setting of decreased cardiac output, decreased effective arterial volume can lead to renal hypoperfusion and, you guessed it, prerenal AKI. A history of heart failure or symptoms that suggest it, things like dyspnea, lower extremity edema, paroxysmal nocturnal dyspnea, and orthopnea, should always raise a red flag. Or, in this case, raise a floppy red heart balloon, which is our recurring symbol for heart failure. Okay, let's talk about medications. Let this RX trash can remind you that several medications are associated with prerenal AKI. That loopy straw in the trash can is meant to symbolize loop diuretics, though any class can lead to volume depletion and prerenal AKI. NSAIDs, symbolized by the inflammation extinguisher in the corner, inhibit COX-1, thereby decreasing prostaglandin synthesis. Since prostaglandins cause vasodilation of the afferent renal arterioles, their removal leads to afferent vasoconstriction and reduced glomerular blood flow. This can cause clinically significant decreases in GFR in patients with already underlying renal hypoperfusion. Angiotensin converting enzyme inhibitors work from the other side, the back end, on the efferent arterioles. Angiotensin II normally causes vasoconstriction of the efferent arterioles, increasing glomerular pressure and GFR. ACE inhibitors take that away, thus decreasing glomerular pressure. Again, clinically significant decreases in GFR are primarily seen in patients with underlying renal hypoperfusion. Okay, on to physical exam. With prerenal AKI, start by assessing the blood pressure, as hypoperfusion itself can lead to decreased renal perfusion. Also, look for signs of hypovolemia like dry mucous membranes, decreased skin turgor, cool extremities, and sluggish cap refill. If you suspect heart failure as the underlying cause, look for the telltale physical exam findings like an elevated JVP, bibasilar inspiratory crackles, an S3 heart sound, and peripheral edema. Also, be on the lookout for stigmata of decompensated cirrhosis like ascites, spider angiomata, caput medusae, and jaundice. And how about labs? We already discussed the creatinine, urine output, and electrolyte shifts that occur in AKI, but let's look at a few specific findings that help us more definitively diagnose prerenal versus intrinsic renal disease. A BUN over creatinine ratio of greater than 20:1 is characteristic of prerenal AKI. When the renal perfusion is decreased, salt and water reabsorption at the proximal tubule is increased. Uremia happens to go along for the ride, getting reabsorbed as well, and raising that ratio. It's kind of like this lady here, raising that BUN bag above her creatinine credit card. Notice too the conveniently placed 20 on her shirt. Next, urine sodium. In prerenal AKI, expect a low urine sodium. Typically, it's less than 20 milliequivalents per liter. Hence the 20 we've incorporated into this fallen salt shaker. Low urine sodium isn't surprising considering the fact that those underperfused kidneys are scrambling to reabsorb sodium with the help of angiotensin II and aldosterone, thereby conserving volume. If the patient has decreased urine output or oliguria, a random urine sodium isn't really the best test because urine sodium varies with urine volume. The FeNA, on the other hand, is unaffected by volume. FeNA stands for fractional excretion of sodium and is symbolized by those FeNA fries. Yum. Remember, in prerenal AKI, the tubules are holding on to the fluid and sodium. This typically translates to a FeNA of less than 1%, which is why we place these fries low to the ground. Probably they're still good, actually. But keep in mind that there are limitations to using FeNA. The whole less than 1% thing is really only true in the setting of significantly reduced GFR and not in more mild cases of prerenal AKI. Secondly, the FeNA calculation involves a single creatinine measurement. That's actually not a very good estimate of GFR. Thirdly, some intrinsic causes of AKI may also have a FeNA of less than 1%. What? That includes acute glomerulonephritis, vasculitis, and contrast-induced nephropathy. In these settings, the GFR might be low, but tubular function is relatively intact, so the kidney is still able to conserve sodium. And finally, prerenal AKI superimposed on chronic kidney disease may initially show a FeNA of greater than 1, since the busted kidney isn't very good at resorbing sodium. The same is true for other causes of salt wasting, like diuretic use. Most diuretics, by design, increase urinary sodium excretion in an attempt to remove volume. So keep in mind that urine sodium and FeNA might not be accurate in patients on diuretics. In patients on diuretics, you can use FeNA's cousin, Phe-urea, or fractional excretion of urea. Phe-urea of less than 35% is consistent with prerenal AKI. Lastly, let's look at the findings on urine microscopy, or lack thereof. With prerenal AKI, the urine microscopy is generally normal with bland urine sediment or a few hyaline casts. Nothing to see here. Move along, people. Alright, let's sum it up with a sample assessment of prerenal AKI. Miss K. Digo is a 64-year-old woman with hypertension who presents with 3 days of vomiting and diarrhea after a cruise. She takes losartan at home for blood pressure and denies any alcohol use. Her vital signs are significant for mild tachycardia, and physical exam demonstrates dry mucous membranes. She also has decreased skin turgor and sluggish capillary refill. Labs show a creatinine of 1.9 milligrams per deciliter, Her baseline from clinic is zero point 0.9 milligrams per deciliter, BUN of 45, and urinalysis featuring hyaline casts. Urine sodium is low with a FeNA of 0.2%. Given her history, physical exam, and lab findings, Ms. Deagle likely has viral gastroenteritis complicated by a prerenal AKI due to dehydration. Alright, time for the plan. We treat prerenal AKI by identifying and treating the underlying cause. So grab a beverage and treat yourself to a brief look at prerenal AKI management. If the patient has clear signs of volume depletion, treatment of prerenal AKI is easy. Just add fluid. Correction of intravascular volume will restore the renal perfusion, and the creatinine should fall within hours. In fact, when the etiology of AKI is unclear, though signs and symptoms are pointing to a hypovolemia and prerenal picture, assessing the response to fluids helps secure the diagnosis. In the setting of prerenal AKI, you should see a creatinine return to its baseline within 24 to 72 hours. Creatinine that does not correct should make you think of intrinsic AKI. IV loop diuretics, like furosemide, are used for diuresis. By reducing intravascular volume in this volume overloaded state, we improve cardiac output and thus improve renal perfusion. In severe oliguric or anuric cases, however, dialysis or hemofiltration might be required to remove the fluid. Prerenal AKI and cirrhosis is treated by holding diuretics and trying to expand the plasma volume, typically with albumin and isotonic fluids. Also, keep an eye out for other complications of cirrhosis, like SPP or GI bleeding, and manage those accordingly. All right, on to the pathologies that affect the kidney directly, intrinsic AKI. To make things easier to think of physiologically, intrinsic AKI can be further divided anatomically based on the primary site of injury. First up, the tubulointerstitium. Injury to the tubular cells can come from direct injury to the cell or by damage caused from within the tubular lumen. And the interstitium, well, it's fair game for almost anything. All right, what should you look for when you're working up intrinsic AKI? The most common cause of intrinsic AKI is acute tubular necrosis, or ATN, which, as the name implies, involves death and sloughing of the tubular cells. ATN is most commonly caused by ischemia. In fact, intrinsic AKI is commonly due to prolonged prerenal AKI because prolonged hypoperfusion will eventually lead to ischemia and necrosis of the tubular epithelium. To help you remember this progression from prerenal AKI to ATN, we've placed this ATTN sign here at the border of the pre and the intrinsic AKI sections, almost as if one moves smoothly into the other. So keep a lookout for symptoms suggesting dehydration, heart failure, cirrhosis, hypotension, shock, and anything else that leads to renal hypoperfusion. ATN can also be caused by nephrotoxic agents. In the setting of rhabdomyolysis, for example, intracellular muscle components, including myoglobin, creatinine kinase, LDH, and electrolytes, are released into the bloodstream and extracellular space. The heme pigment from myoglobin directly damages the tubular epithelium. Tubular obstruction and vasoconstriction are also thought to play a role here. Look for an inciting event like a seizure or a crush injury, muscle ischemia, prolonged immobility, excessive exercise, or statin use. Patients typically present with myalgia, weakness, dark colored urine, all due to myoglobinuria. Did your patient just come back from imaging, perchance? IV contrast, symbolized by the contrast of the yin and yang, can lead to ATN, so-called contrast nephropathy. Patients with underlying CKD, diabetes, older age, or hypovolemia are especially at risk. Like rhabdo, the contrast directly damages the tubular epithelium. Tubular obstruction and vasoconstriction are also thought to play a role here. Luckily, contrast nephropathy is becoming less severe and less common due to improvement in the contrast material itself. Look for that creatinine to rise about 24 to 48 hours after contrast exposure and begin to fall 3 to 5 days later. There's also a long list of nephrotoxic medications associated with ATN, and we've highlighted a couple classic agents in this antibiotics-themed waste bin. Vancomycin, represented by the discarded toy van here, and aminoglycosides, represented by the discarded. Is that like a ninja sai? Man, what part of town are we in? All right, moving on from the tubes to the interstitium. Acute interstitial nephritis, or AIN, will be represented by the flame inside this scalding hot, kidney shaped cup of coffee, evoking an image of an inflammatory infiltrate in the kidney interstitium. The classic triad of AIN consists of rash, fever, and eosinophilia as embodied by this blotchy red apron. The classic triad of AIN consists of rash, fever, and eosinophilia as embodied by this blotchy red apron, flame bandana, and pink polka dot shirt. Though this is the classic triad, all three are present in only about 10% of cases. Use it more so to remember eosinophilic syndrome symptoms in general, i.e., fever, rash, eosinophilia, and weird stuff in the skin, lungs, GI tract, and kidneys. And of course, with AIN, be sure to review those meds. Common culprits include antibiotics like trimethoprim sulfamethoxazole and other sulfa drugs, penicillins, cephalosporins, ciprofloxacin, and rifampin, which is why we've drawn in another antibiotics themed trash can, which includes our stinky sulfa drugs, sulfa eggs, and our purple penicillin pencil at the top of the pile. This trash bin is also a fitting visual metaphor for the utter trash bin of drugs that could potentially cause AIN. These include NSAIDs, loop and thiazide diuretics, PPIs, cimetidine, allopurinol, indinavir, and mesalamine. Put simply, a lot of drugs, so always keep AIN in the back of your mind. The next category of intrinsic AKI is crystal-induced AKI. We're back in the tubule for this one, where intratubular precipitation of crystals causes damage by direct entry to the cells or by obstructing the tubular lumen outflow, which results in back pressure and injury. I mean, just look at all these shards of glass here, causing all kinds of obstruction. Look for crystal induced nephropathy when IV acyclovir is in the medication history, as with patients with HSV meningitis, HSV encephalitis, or disseminated herpes zoster. Ask about recent ingestions to look for ethylene glycol nephropathy, especially if the patient is altered and has a history of alcohol abuse or homelessness. And the shards of glass falling from the screen, that's to remind you of tumor lysis syndrome, which results in urate and calcium phosphate crystal accumulation in the tubules. Tumor lysis syndrome commonly occurs with administration of cytotoxic chemo, especially during the treatment of hematologic ones like leukemia or lymphoma. It may occur spontaneously as well. For more on tumor lysis syndrome, head on over to Cute Luke's Acute Leukemia Sketch. And you know what else can precipitate in the tubules? Immunoglobulins, or at least little bits of immunoglobulins. The monoclonal gammopathy syndromes, such as multiple myeloma, are associated with a whole range of kidney disorders that can present as acute or chronic kidney disease, including AL amyloidosis, light chain deposition disease, and light chain cast nephropathy. In fact, 20 to 50% of these patients will have either acute or chronic kidney disease at the time of their diagnosis. At Sketchy, we symbolize multiple myeloma with antibodies in a spine, representing the classic lytic bone lesions and immunoglobulinemia. The most common cause of AKI in patients with multiple myeloma is light chain cast nephropathy, in which immunoglobulin light chains filtered at the glomerulus precipitate in the tubule, causing the formation of obstructive casts. As for clinical presentation, the crab sticker on the counter should remind you of the classic crab symptoms that go along with multiple myeloma, including hypercalcemia, renal failure, anemia, and bone pain. Next up, the blood vessels, which are pretty important in the kidney to say the least. Intrinsic AKI is a complication of the so-called thrombotic microangiopathies, which cause thrombosis of the small vessels and arterioles, hence the arteriolar ponytail. Thrombosis uses up platelets and tears up RBCs, so we featured the two prominent features of these disorders, thrombocytopenia and microangiopathic hemolytic anemia, or MAHA. This is depicted by broken plates and this MAHA kid in the employees only area. Two classic causes are TTP and HUS, though TTP typically is not associated with clinically significant kidney dysfunction, and HUS is mainly in children. However, endothelial damage and thrombosis in small vessels can also occur with hypertensive emergency, systemic sclerosis, especially in scleroderma renal crisis, and certain drugs. Sticking with the small vessel theme here, let's talk about cholesterol. Manipulation of arteries rife with atherosclerotic disease can cause dislodgement of cholesterol crystals and debris, which shower into the distal circulation. This is called atheroembolism. This can also occur spontaneously in patients with extensive atherosclerotic disease. If the small renal afferent vessels are affected, this can lead to AKI. But that's not all. The clinical presentation varies widely depending on where the emboli end up, including stroke symptoms from CNS involvement, amaurosis fugax from retinal artery involvement, or abdominal pain due to intestinal ischemia. Watch out for those fat drops. Other signs of cholesterol embolization include levator reticularis, hence the net like purple pattern on his pants, and blue toe syndrome, represented by his blue kicks. Keep the risk of cholesterol emboli in mind when you send your patient off to coronary angiography, thoracic aortic aneurysm repair, or other aortic procedures. And finally, our last category of intrinsic AKI, glomerulonephritis, represented by the glomerular red bendy straws. The etiologies are numerous. Just think back to the Great Nephritic Wall. Glomerulonephritis can follow acute infection, or it can occur in the setting of chronic infections like hepatitis or HIV. It's also seen in the setting of autoimmune diseases like lupus, as well as a wide variety of immune complex and vasculitis syndromes. And while nephrotic syndrome is also associated with intrinsic AKI, it's actually pretty rare. For the full clinical presentation and workup of nephrotic and nephritic syndromes, check out the next sketches in this chapter. We'll be keeping it pretty brief here. Okay, on to the physical exam. Not surprisingly, the findings will vary based on the underlying cause, but there are a few important things to remember. Prolonged prerenal AKI can progress to ATN, so make sure to look for signs of hypovolemia, shock, heart failure, and cirrhosis. Fever, as well as rash, are associated with acute interstitial nephritis, it being an inflammatory reaction and all. If cholesterol emboli are suspected, the physical exam can help you ascertain the extent of the embolization. Patients with transient vision loss should undergo an ophthalmologic evaluation. Perform a full neuroexam to assess for stroke. Abdominal tenderness could be a sign of intestinal ischemia. Lastly, assess the skin for levator reticularis or darkened ischemic spots on the feet and toes distal to the embolized small vessels. History and physical exam are always important, but as we mentioned before, AKI is largely a lab-driven diagnosis. BUN and creatinine ratio with intrinsic AKI is typically closer to the normal value of 10 to 1 as opposed to the 20 to 1 of prerenal AKI. With prerenal AKI, tubular function is preserved, and the increased urea reabsorption is a mechanism to retain as much water as possible. With intrinsic AKI, however, the tubules are dysfunctional, with a resultant lack of concentrating ability. In rhabdomyolysis, the serum creatine kinase, or CK, a muscle enzyme, will be dramatically elevated. It's typically in the thousands. Peripheral eosinophilia, depicted by this pink polka dot peripheral shirt, is supportive of AIN. Ethylene glycol poisoning causes an anion gap metabolic acidosis. It's the E in mud piles. An important additional finding with ethylene glycol poisoning is an elevation in the osmolar gap, meaning the difference in the measured osmolality and the calculated osmolality will be greater than 10. This indicates that there are osmotically active substances, in this case ethylene glycol, sneaking around in the background. That's like buy one gap, get one gap free. In the setting of tumor lysis syndrome, cells dump their intracellular contents, leading to elevated phosphate, potassium, and LDH. Phosphate, uric acid, and other anions bind calcium, and this leads to hypocalcemia too. Hyperuricemia, which goes hand in hand with increased uric acid excretion, can lead to precipitation of uric acid in the renal tubules, inflammation, and renal vasoconstriction, resulting in AKI. Similarly, hyperphosphatemia can lead to calcium phosphate deposition in the renal tubules, in case you needed another reason for AKI. As discussed previously, the thrombotic microangiopathies are characterized by thrombocytopenia and microangiopathic hemolytic anemia, or MAHA. That means schistocytes, which take the form of so-called helmet cells on peripheral smear. Other typical features of hemolytic anemia include unconjugated hyperbilirubinemia, increased LDH, reduced serum haptoglobin, and increased reticulocyte count. Check out our liver lab sketch for a more detailed discussion of hemolysis labs. And finally, let's take a peek at that P, shall we? Recall that with prerenal AKI, in which the tubules are still functioning, there was a low urine sodium as the kidneys held on to sodium and volume. In intrinsic AKI, however, the tubules are on the fritz. This means that the concentrating ability of the kidney goes, and with it, so goes the sodium. A urine sodium of greater than 40 millimoles per liter suggests intrinsic AKI due to tubular dysfunction, hence the two cleverly 20-shaped salt shakers. FeNA is based on sodium excretion. Remember, it stands for the fractional excretion of sodium, after all. So it's no surprise that with the higher proportional urinary sodium excretion in intrinsic AKI, the FeNA is higher too. A FeNA over 2 suggests tubular dysfunction and intrinsic AKI, hence the two salty FeNA fry baskets next to those urinary salt shakers. It's important to note that some causes of ATN and intrinsic AKI may present with a low FeNA, sometimes even less than 1%. This includes acute glomerulonephritis, vasculitis, contrast-induced nephropathy, and rhabdomyolysis. In these settings, GFR may be low, but tubular function is relatively intact, so the kidney is still able to conserve sodium. So don't be duped. Be sure to look at the clinical picture as a whole. Diuretics, which can cause you to dump sodium in the urine, make FeNA unreliable in intrinsic AKI, just like in prerenal AKI. So turn to the Phe urea, as with prerenal AKI and in the setting of diuretics. So turn to the Phe urea, as with prerenal AKI and diuretics. A Phe urea of greater than 50% is consistent with ATN. While urine microscopy is typically boring with prerenal AKI, there's a whole mega variety of findings in intrinsic AKI. The N in ATN is necrosis, and that's what you'll see in the urine, or in this case, on the floor. That brown scoop of muddy ice cream in the yellow puddle is there to remind you of muddy brown casts, a pathognomonic finding in ATN composed of the dead, sloughed tubular cells. 5-second rule? Works for me. Yum, 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 yum. Sweet. Now on to the tangy barbecue sauce. Up on the rhabdomyolysis sign, we've added some brown barbecue dipping sauce to remind you of the red to brown urine in the setting of myoglobulinuria. Think of it as dipping sauce because in rhabdomyolysis, a classic finding is large blood on dipstick. Though remember that the dipstick is really measuring heme, the heme in all that urinary myoglobin, that is. In acute interstitial nephritis, there is inflammation in the kidney itself, which typically leads to white cells and white cell casts visible on urine microscopy, sort of like this white cup and stack of white cups on the wet floor. Next, glomerulonephritis, which will likely exhibit an active urinary sediment, with RBC casts symbolized by these red stacked cups, as well as dysmorphic RBCs, illustrated by the crumpled red cup. Proteinuria on dipstick is common as well, so we threw in a frothy, proteinaceous chicken leg, just for good measure. As you might guess, the dipstick will in fact be positive for heme, with all that hematuria going on. So we've brought in some reddish-brown barbecue dipping sauce, also here to remind you of the possibility of gross hematuria turning the urine a red to brown color. So-called Coca-Cola urine is a classic presenting feature of the post-infectious causes of glomerulonephritis. Aside from cells and casts, be on the lookout for crystals during microscopic evaluation of the urine sediment. Acyclovir can cause needle-shaped acyclovir crystals visible on UA, which probably look a lot like the glass shards falling from the acyclovir recycling bin. With ethylene glycol poisoning, look for envelope-shaped calcium oxalate crystals, sort of resembling the envelope-shaped antifreeze containers here. Tumor lysis syndrome can result in uric acid crystals, which can be needle or diamond shaped. In the setting of a thrombotic microangiopathy, hemolysis can cause hemoglobinuria, which can give the urine a red to brown color on gross inspection. So in comes the bloody barbecue dipping sauce yet again. Hemoglobinuria will also cause a urine dipstick to test positive for blood, but remember it's really detecting heme, my friends. No RBCs in the urine necessary. Otherwise, the vascular causes of intrinsic AKI, including thrombotic microangiopathy and atherosclerotic disease, have a pretty bland sediment on UA, with no cells or cast to speak of. That's why we place those characters in the back above the bland looking urine bucket. As for multiple myeloma with AKI, the dipstick probably won't report anything interesting, and the urine sediment will likely be pretty bland as well. That's because the most common cause of AKI in patients with multiple myeloma is light chain cast nephropathy. These light chains are not detected on the dipstick, which measures albumin only, and these light chains gunking up the tubules don't form casts, which are usually cellular. Patients with AKI and a higher risk of multiple myeloma will sometimes get an SPEP and a serum light chain assay to screen for disease. Check out our medieval myeloma sketch to see how SPEP and serum light chains are used for screening and why UPEP is a good way to look for these pesky light chains in the urine. All right, let's take a look at a case of intrinsic AKI. Miss Trinsic is a 46-year-old female recovering in the ICU after a period of septic shock secondary to UTI. She was on vasopressors for nearly 8 hours during resuscitation, but has been hemodynamically stable for the past 24 hours. Labs show a creatinine of 2.9 milligrams per deciliter, up from 1.2 milligrams per deciliter on admission. Urine sodium is 48 millimoles per liter, and a FeNA is 2.4%. Urine microscopy shows granular muddy casts. Given her history and lab findings, she most likely has intrinsic AKI due to acute tubular necrosis following hypotension and renal ischemia. As with prerenal AKI, we treat intrinsic AKI by identifying and treating the underlying cause. So grab a seat and treat yourself to a brief look at intrinsic AKI management. With ischemic ATN due to a prerenal process, treatment is supportive and involves optimizing hemodynamic status to boost perfusion and in fact, IV fluid therapy is crucial for preventing AKI in multiple settings. In patients with rhabdo, correct volume depletion, which minimizes ischemic injury. Increasing urine flow also helps wash out obstructing casts, as well as prevent cast formation by diluting the concentration of heme in the tubular fluid. Increasing urine flow also aids in potassium excretion. With contrast nephropathy, the key is to start hydration before the contrast load, so start IV isotonic fluids a few hours before the procedure or scan. This is only in high-risk patients, and by high risk, we mean those with a decreased baseline GFR. The evidence for volume expansion is mainly derived from patients undergoing angiography. Patients undergoing CT with contrast, on the other hand, do not typically need special precautionary measures unless their GFR is severely depressed, below 30 in other words. To decrease the risk of AKI from IV acyclovir, give IV isotonic fluid in patients who may be volume depleted. The risk of tumor lysis syndrome kidney injury can be reduced with IV fluid hydration and prophylactic allopurinol. Treat really high uric acid levels with raspuricase. Ethylene glycol poisoning is treated initially with fomepizole, an alcohol dehydrogenase inhibitor. In severe cases, patients may require emergency hemodialysis. For AIN due to a drug, stop it. In many cases, AIN will resolve with withdrawal of the agent. In fact, all these intrinsic cases, check your patient's med list and look for drugs that might be increasing the risk of renal injury. Pre-kidney, inside the kidney, and now part 3, past the kidney. Obstruction of urine flow anywhere past the glomerulus can lead to increased intratubular pressure and therefore reduced GFR, though it's thought that impaired renal blood flow and inflammatory processes contribute as well. In patients with 2 normal kidneys, obstruction needs to be bilateral in order to see a rise in creatinine, since one functioning kidney will pick up the slack for the other one. With urinary obstruction distal to the bladder, patients may describe difficulty urinating and a weak urinary stream, kind of like this trickling water cooler here. If the bladder starts to get more and more distended, they may describe pain or a sensation of uncomfortable fullness. Pain may also be a sign of secondary infection. So, what refuses to go with the flow in the first place? The most common cause shouldn't be surprising: prostatic urethral obstruction due to BPH or prostate cancer. Sort of squeezes the prostatic urethra, just like the death grip this patron is exerting on the urethral door handle. And those cancer crap shorts? Let them remind you not only of prostate cancer, but any pelvic, abdominal, or retroperitoneal cancer, even gynecologic cancers like cervical cancer. A bladder that refuses to empty or doesn't expand to accommodate urine can also be thought of as an obstruction. Let this sparking dysfunctional wire remind you of neurogenic bladder. Renal stones won't usually cause postrenal AKI since the other kidney helps out. However, patients with a solitary functioning kidney due to a congenital abnormality or a history of nephrectomy will develop postrenal AKI with unilateral obstruction of the functioning kidney. And nothing obstructs a ureter, or a doorway in this case, better than nephrolithiasis. With stones, look for classic flank pain radiating to the groin, nausea, vomiting, and hematuria. Don't get too excited though, there's typically not much in the urine sediment. To remind you of the clean UA, we've put this clean yellow puddle. Well, about as clean as a puddle of urine in a food service establishment can be. If you suspect postrenal AKI from urinary obstruction, start off with a renal ultrasound, symbolized by our recurring ultrasound bullhorn speaker. Renal ultrasound might show bilateral hydronephrosis, which is a dilation of the renal pelvis, and calyces due to back pressure from the obstruction, as illustrated by the dilated ribbon connecting to this renal balloon. It takes time for parenchymal changes to occur, however, so remember that ultrasound can be normal early in the course of obstruction. The ultrasound can also be used to estimate bladder volume. A volume of greater than 300 cc's in a patient unable to void suggests urinary retention. By the way, if stones are suspect, skip the ultrasound and go straight to non-contrast CT of the abdomen. Okay, let's take a look at a sample patient. Mr. Abe Struction is a 70-year-old male with hypertension and BPH presenting with abdominal discomfort. He reports weak urinary stream for years and an acute worsening of difficulty initiating urination, as well as urgency and frequency over the past week. Physical exam reveals a distended bladder, and a DRE confirms a smooth, non-tender, symmetric enlarged prostate. Labs are significant for a creatinine of 1.6 milligrams per deciliter, previous baseline was 1, and a urinalysis unremarkable. His presentation is consistent with acute postrenal AKI due to worsening BPH. In the setting of urinary retention, bladder catheterization should be performed both to confirm the diagnosis and to relieve the discomfort of a full bladder. Urine output of 200 to 400 cc's or more in the first 10 to 15 minutes after the insertion suggests urinary retention. With output over 400, the catheter is usually left in place. You can also consider leaving the catheter in place if the output is over 200, depending on the clinical scenario. For patients who have contraindications or fail urethral catheterization, consider placing a suprapubic catheter to relieve the bladder distension. Unfortunately, if the obstruction is above the bladder, as with a tumor impinging on both ureters or a large stone in the ureter of a solitary kidney, a Foley won't reach high enough. In these cases, a catheter, called a nephrostomy tube, can be placed percutaneously straight into the renal pelvis. This allows the urine to drain while bypassing the ureters, bladder, and urethra. Ureteral stenting can also sometimes be used to relieve the obstruction if it's not too severe. The treat yourself mantra applies here as well. The next step in management involves treating the underlying cause of the obstruction. For example, a patient with BPH will typically be started on an alpha-1 inhibitor at the time of catheterization. Now that we've gone through all the subtypes of AKI, let's review some of the general management principles for all types of AKI. The logic behind the first one is easy in theory, but oftentimes it's poorly executed. Avoid nephrotoxic drugs. Some nephrotoxins, like gentamicin or contrast, are easily recognized. However, care must be taken to always check for nephrotoxicity and patient factors that may make some drugs more harmful than others. So, always pay attention and be responsible using NSAIDs, ACE inhibitors, and ARBs, acyclovir, as well as antibiotics like aminoglycosides, vancomycin, trimethoprim sulfa, and penicillin, among many others. And of course, always remember to renal dose meds when appropriate. IV contrast should be avoided if possible, but you'll never be able to just abandon it. Just be sure to take the proper precautions, such as ensuring adequate hydration beforehand and minimizing total dose given. The great thing about renal failure as opposed to hepatic failure, though, dialysis. If all else fails, you can temporarily or even permanently provide renal support via dialysis in any of its many forms. We'll go over this in a lot more detail in the chronic kidney disease sketch coming up. But for now, just remember the vowels to indicate dialysis: refractory acidosis, electrolyte disturbances, ingestions like lithium, overload of fluid, that is, and last but not least, uremia.